Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Hello, everyone. Welcome to the Oncology Revolution Podcast. I'm your host today. My name is Raquel Marish. I'm an occupational therapist with an executive MBA, and I'm working as project coordinator at the European School of Lifestyle Oncology. Today, our guest is Jessica Gorzelitz. She's a researcher and lecturer with a PhD whose work bridges kinesiology and epidemiology, with a special focus on physical activity in cancer survivorship. She leads the Physical Activity and Cancer Survivorship Lab at the University of Iowa, and we are also very lucky to have her as a lecturer on the Advanced Certificate in Lifestyle Oncology here at our school. Jess, thank you so much for being here.
Thank you for having me.
I would love to start by exploring what drew you into kinesiology and epidemiology, and how did you end up focusing on cancer survivorship?
So I have been a lifelong exerciser. I started exercising with my dad when he took me to the weight training room. When I got to college, I didn't realize that exercise science or kinesiology could be a major. So when I got to college, it was super exciting that you could study kinesiology or human movement, because it really applied to what I saw in the gym, and it added science to the art. And I learned in college, I was a kinesthetic learner. So it was really important for me to apply and do with my training, such that when I was in college, I worked as a personal trainer and worked one-on-one with folks, teaching them how to exercise. And my main bailiwick was strength training or resistance training, teaching older women how to bench press, how to engage your core during a squat, what are the major muscle groups, some of those typical trainings in strength space. And I liked it. I liked being a personal trainer, but it was really challenging for scale. It felt like I was working all the time and I was helping all of these people. And there were so many people on the wait list and who still had questions and who still needed to learn about how to strength train, which is actually what drew me to my graduate degree in epidemiology, learning how do we scale this at a population level? How can we help make bigger impacts instead of just one-on-one, personal training. During my graduate studies in epidemiology, I was able to marry my two interests of physical activity and epidemiology into physical activity epidemiology. And I was also able to pull in a third interest of mine, which is how exercise can help folks who have survived a cancer diagnosis. My family, like many people, we've been touched by cancer. I've lost family members. And I remember taking a class, learning about the 2019 publication about exercise and cancer prevention and exercise and cancer survivorship, that there was good evidence that not only could exercise and physical activity prevent certain types of cancers, but it was really linked to a lot of outcomes that could help improve life for these folks. So just following one interest at a time allowed me to kind of blend these multiple areas of interest into what I'm doing today.
Thank you so much for sharing your touching story. You've got a strong background in population science, but you're also working on practical real-world interventions. How do you bring together those two worlds today?
Yeah, so I am in a state, I'm in Iowa, where we have a lot of rural population. About 40% of our state is rural. So population science is helpful to understand what's going on at a big picture level, to see what could be sustainable or reachable. The metaphor is like cars. If you've got a Porsche, it's really fancy. It's got all of these gears and bells and whistles, and it works extremely well. But knowing most people can't afford the Porsche, should you invest in that? And I think for me, I bring my population science hat to think about what is going on with the bigger population. When we try our behavioral interventions, we're trying to minimize cost to the participants and maximize reach so that we can really reach as many people as possible. Other researchers will have more sophisticated, more tech-intensive, higher touch, and these interventions are great. I like to focus on what could reach the biggest amount of of people, and keeping that in mind from a population science perspective, are folks who have different needs, different access, and cost can often be a barrier.
That's a great perspective. Let's dig a bit deeper into the role of exercise itself, because it's such a central theme in your work. And I wanted to know, what does the current literature tell us about the impact of physical activity on outcomes in cancer survivors?
Absolutely. And this is, I'll put my lecturer hat on that, physical activity and exercise, I use some of these terms interchangeably. And I think for clarity, I'd like to specify. So when I talk about physical activity, we're looking at any voluntary bodily movement that increases energy expenditure above baseline. So getting up from your office to go fill a cup of water, getting the mail, those are all forms of physical activity, right? It increases your heart rate. Not all physical activity necessarily is for an exercise benefit. Going for a run to improve your VO2 max is a type of physical activity, but then we can subsection that into exercise. That's done for a physiologic or a fitness benefit. And that's important when we look at the literature, because different studies will measure different aspects. In epidemiology, especially physical activity epidemiology, we're almost always looking at physical activity exposures, where we ask individuals to quantify the total amount, volume and intensity of what they're doing. So we'll often ask people about, what are you doing at home in the household, like vacuuming or doing dishes or sweeping? Those are all physical activities. I don't think those are done for exercise benefits or physiologic benefits. But we also ask about people, what do they do in their leisure time, and what are they doing for transportation? Of course, we have experimental studies where we can exercise folks and we can ask them to do certain training plans or certain exercise exposures. Or even in epidemiology, we can ask people, what were you doing for exercise or for a fitness benefit? So the literature writ large will tell you that physical activity after a cancer diagnosis is generally good. Physical activity is associated with lower risk of mortality, and for some cancers, progression-free survival. When we look specifically at exercise after cancer, that there is where we can really start to see some of the fitness benefits. So for example, if a patient has fatigue following their exercise treatment, if they have fatigue after their cancer treatment, we have specific levels of exercise that are associated with improvements in that fatigue symptom. And while physical activity would probably help with fatigue per se, we know that following this exercise prescription from the literature, seeing all the body of evidence, individuals can see an improvement in their fatigue, for example. And there are several symptoms we know about fatigue, health-related quality of life, sleep, bone health. Some of these really commonly related or commonly reported symptoms from survivors are heavily influenced by exercise, both aerobic and resistance training.
Thank you so much for clarifying and for shedding the light on the difference between physical activity and exercise, because most often people assume they are the same, and they are not. So thank you so much for clarifying that. A lot of people still have misconceptions about exercise after cancer. What are some of the most common ones you come across?
I think this is a great question. And it's one of the reasons I love my job. I can be on an airplane and talk about my work, and or I could be, in a coffee shop, and you get a lot of these misconceptions. In our work, what we see a lot of is that people think they can't exercise because of X. They think they've got, I've got a bad back, so I can't go for a run. I've got an artificial knee, so it's inappropriate for me to do any resistance exercise. I can't afford a gym membership, therefore I can't exercise. So I think one of the biggest things that comes to my mind is that people have a perceived barrier, and that barrier means no exercise. And the perceived barriers are reality. If you think you can't do something or you shouldn't do something, that's the truth. So when we do behavioral interventions, or when we do our studies, that is one of the big things we work with participants on, is that educational aspect. We don't want to minimize someone's concerns, but we can provide evidence and explain, for example, for the individual who's got a bad back, We don't necessarily do axial loading exercises. We do lighter intensity band exercises to help control any pain or concern there. And of course, the big one is that you don't have to run for a fitness benefit. You can increase your heart rate going for walks. We have a lot of participants who bike or do other aerobic activities that aren't running. So I think that's where fitness professionals can come in and research can help to sort of add that educational barrier. There isn't one prescription. There isn't one way to improve health or fitness. Exercise can look like a lot of different things, and that we can accommodate a lot of the physical and environmental barriers to accommodate exercise after cancer.
Sure. And how do you personalize those recommendations when working with very different types of survivors? Because as you said, it is not one thing for all. So what should we do?
Yeah, it's a good question. And I don't have all the answers, but personalized recommendations are a good place to start. What we will do when we're running our trials, we'll often use a behavioral framework or a behavioral theory to understand the way a participant understands their behavior, some of their barriers, and some of their facilitators to their behavior change. So for example, with the social cognitive theory, we will take into consideration environmental factors that are mediated by self-efficacy. So whether we can help foster self-efficacy for a certain population, build their competence, build their experiential learning to help improve their behavior is one of the ways that we can mechanistically change their behavior. But I agree, the one thing to avoid is the one size fits all approach, right? It's not this or that. What we will experience a lot is giving a lot of latitude, and we call them progressions and regressions. So for example, if we want an individual to work their chest muscles, their anterior chest, we'll give one version of the exercise. We'll explain how to make it harder. We'll explain how to make it easier. And how does one monitor the intensity? So it's up to the individual. We don't live in their body. We can't objectively tell them if it's too hard or too easy. But giving them, again, that education and the guidance for how they can help make those selections. When we run our protocols, we are often working with our more specific populations. So we'll be working with women on aromatase inhibitors for breast cancer. We're working with women who have just received radiation therapy for endometrial cancer. We're working with patients who are preparing for chemotherapy for their pancreatic cancer. So in the study context, we can provide some of those bigger parameters because we know that these people kind of cluster together. But when talking about exercise recommendations writ large, it is helpful to sort of talk about the complexity and the ways to achieve these parameters without being very prescriptive.
Thank you for that. That really highlights how complex survivorship can be. And one thing is knowing that exercise is important. And I think most people already recognize that, but getting people to actually stick with it, it's very different. So I would love to hear your thoughts regarding behavioral change that you have mentioned and the role also of the digital tools here. So when it comes to actually keep people moving after cancer, what do you think matters most? Is it good information? Is it accountability, emotional support, maybe something else, maybe all of the above? What is your perspective?
Yeah, I think it's all of the above. It's all of the above, and the answer is it depends. One of the limitations in our field, and certainly something with my own work, you bring up a great point about long-term behavior change. We can get people to, it's pretty, I shouldn't say easy, but it's relatively easy to get a person to change their behavior for a couple of weeks or even a month. But understanding how exercise physiologically improves the body and health outcomes, what's really important is that this becomes a lifestyle, that it extends far beyond the intervention period. And in my experience, we haven't had those long-term outcomes of, 1, 5, 10 years down the road. I think the field is moving that way, but it's hard to say that, my little study changes someone's life. What we can see, I alluded to those behavioral interventions before. in my experience, especially working with older postmenopausal women, the accountability and the social aspect is surprisingly strong. The patients and the survivors will work with our study coordinators, our health coaches, and they develop a very strong rapport. This person or these survivors will interact with the study staff and they'll bring questions, they'll bring modifications. They'll ask, I'm going on vacation. How do I modify my exercise schedule? Or my son is getting married. Should I wear my Fitbit? Should I take it off? So I think the accountability and emotional connection is very strong. As to the social aspect of it, there's a lot of individual variation though. We certainly have participants who, if we gave them the plan, they would run with it without any intervention from us. I personally think that I'm that type of person. Tell me what I need to do and I will do it on my own, which makes running these types of trials complicated and exciting because you have to come up with a framework and an approach that will work for your average person, knowing that there is a ton of variability. So again, I think it's helpful to have many tools in the toolkit, and it's hard to know for sure which one will be the most effective for an individual.
For sure. I actually think I would not be that kind of person who would stick with it. I would need some motivation along the way. So, in your area of expertise, would remote and distance delivered interventions help with it? So, why are those important in survivorship care today?
Yeah, I think they are one tool, and I still very much like them. They were really effective during the pandemic, when people didn't want to necessarily or wouldn't or couldn't come in person. But I alluded to the rural aspect of it and the geographic piece. So I think remote distance-based interventions can be quite effective for certain groups of populations. They minimize that transportation time. People don't have to drive in to see us. We could quick hop on a Zoom, see how things are going. You can show me your form. I can talk to you about it. I can give you that motivation remotely. So again, to that point about scale and reaching large numbers of people, it's pretty cost effective. People don't have to spend their gas. My coordinators can stay in an office and book multiple appointments, which is great. It's not perfect for people who need that higher touch or a kinesthetic feedback would be helpful. There are also patients and survivors who are higher risk, so such that a remote distance-based intervention might not be the safest approach for them. They might need someone physically there with them in case something were to happen. So again, I think in general, it is an effective approach and it can be used for large groups of people. But again, there isn't one that is gonna help here. There isn't one prescription that will work for everybody all the time. Given that I live in Iowa and we have a large rural population, I am really encouraged by the reach and the scale that we can get out to all corners of the state without folks having to drive several hours to see us.
For sure, that is very, very helpful. But as you said, technology will not replace us, and it will always be needed, the in-person care in some cases, right? And
Absolutely.
regarding motivation again, how do you encourage someone who's feeling exhausted, anxious, or maybe even discouraged after treatment?
Yeah, it happens. It happens quite a bit. One of the things we talk about in our interventions working with folks is preparing for lapses and sort of like getting away from this perfect mentality. All of us miss workouts, all of us, sit instead of stand, we don't take the most physically active option. And it can be really discouraging to have this like perfect mentality that I have to do everything great. The world is a stressful place. We will get fatigued, bad things will happen, mood will change. So one of the things we talk about is preparing for those lapses. What are you going to do to get back on the horse? It's okay to miss one. It's okay to miss a couple, but giving up after that is not the best approach. The anxiety piece is huge for folks, especially with the uncertainty of cancer. We've worked a lot with folks who are in that active surveillance period where they are being monitored because they are at high risk of recurrence, and talk about a stressful time, right? You have a scan, you've got your blood work, you don't know what it's going to say. For some people that can be really motivating to take all that anxious energy and put it into exercise, but it's a human reaction to be worried about those things. So I think flexibility is one of the things, in addition to, not being perfect and planning for lapses. And I've said it before, but the personalized approach is a huge part of this, right? It's not going to be one size fits all for everybody.
Of course. And how do you feel the importance of the community or social connection in the way that it is helping people to stick with behavior change long term?
So I think it's human. Community and social connection is huge. What I think is really interesting, some of the scholarship that we've done, particularly in endometrial cancer, we've done some focus groups and some qualitative interviews talking to women, indicating that a group-based class or a social connection like based exercise program might not be the most desirable due to fears of competition or body images concerns. Women with endometrial cancer have a high prevalence of obesity, and they talked a lot about having weight stigma, or biases on the way that they are perceived, and not necessarily feeling welcomed in exercise settings, which is really interesting because exercise, especially in-person exercise, there's a huge social aspect to it. Like when I train, I've got my crew, I've got my buddies, I see these people all the time on my training schedule. And it's nice, not just a fitness benefit, but for checking in with your peers, and feeling part of a group. So that was a really interesting finding. And of course, that doesn't mean everybody all the time, but it was a somewhat novel finding. Community and social connection might not be related to your exercise group. It can for some people, like me. I want my crew, my training buddies, like that's my people. But we've also seen participants talk about, their granddaughters, or their husbands, or their children being their accountability buddy, or it's people in the neighborhood that either they exercise with them, or they can talk about exercise with them, or they can just socialize. I think isolation can be a really dangerous thing, which can also prohibit exercise behavior if you're feeling really disconnected and isolated. So I think the literature will tell you that community and social connection are highly important for long-term behavior change. But what exactly that community looks like, and in what context, I think is still pretty variable.
For sure, I completely agree, and that's fascinating. That the idea of social community, it is just one thing, and it is not. It can be family, as you said. So it's very interesting to think in that perspective. It also makes me wonder about the big picture, especially in how professionals are trained to support survivors. Let's shift the conversation into education. From your perspective, what are the most important gaps in how healthcare professionals are trained to support cancer survivors today?
Yeah, it's a big question, and cancer survivorship is an interesting topic. And 40 years ago, it was less important because we didn't have people weren't surviving their cancer as much as they are now. Now, today, breast cancer, the 5-year survival rate across all stages, I think, is northwards of 95%. So as we've had investments in cancer detection and importantly, cancer treatment, we're investing all this money to catch the cancer, to treat it. Folks are living, and they're living well, and they're living longer. Those treatments, that experience, the healthcare system isn't really set up to necessarily support cancer survivors. For example, in the US, a lot of the supportive care services like exercise, they're not covered by insurance. They're not billed. This isn't part of routine care. If you go in to the doctor's office and you get diagnosed with strep throat, you get antibiotics. That is the typical course of treatment. That's covered. That's what happens. In cancer, you go through cancer treatment, you get diagnosed, you ring the bell, you're not automatically referred to exercise resources. You're not necessarily seen by a physical therapist. Your occupational therapy needs might not be addressed. So systematically, we're trying to make some things fit over here that are kind of challenging to make fit together. The providers that we work with, the clinicians, oncologists, PAs, NPs, they are very, very invested in making sure that their survivors live long and live well. The issue is really how that system is built to support that, not only from a referral and monitoring perspective, but unfortunately for us, the way that insurance and billing is set up. The joke is that cash rules everything. So if there isn't billing, if there isn't insurance, if it's not structurally set up from an organizational perspective, it's really challenging to support cancer survivors, especially through exercise.
Sure. Thank you for sharing that perspective. Do you feel that exercise and physical activity are still undervalued or underrepresented in oncology education? And if so, why might that be?
So I think I can offer perspectives from the United States and also an undergraduate exercise training perspective. I'll tell you, in our department, we are about to launch an exercise oncology course to expose undergraduates to the evidence for exercise and cancer. And that is the first class in our department that is specific to cancer. So I do think it is underrepresented in our undergraduate curriculums for sure. You know, a lot of schools will have classes about exercise and cardiovascular physiology or neurophysiology. Cancer is becoming so common, and I would say so interesting, that it really should be incorporated at the undergraduate level, at least in an elective. For medical students or other providers, it's challenging because they have so much curriculum to cover. You know, the insurance, all the diagnostics, all the systems there. I would like to see there to be more representation in their training so that there could be more exercise, health coaching, motivational interviewing. I am not a physician, so it's easy for me to be on the outside and quarterback armchair and say, like, I think there should be more. I will say there is a lot of good momentum, though, where people are really starting to tune in to how beneficial cancer and exercise can be. For example, Carrie Kernier's trial, the challenge group, seeing how effective exercise was for improving survival in colon cancer, I think is really helping providers, physicians, the medical community understand that this isn't something just to make people feel good and look good. This is medicine, and this is helping people live long and live well.
That's amazing. Thank you for sharing those perspectives. And just as we are reaching the end of our episode, I would like you to leave a message for our audience.
Oh, this is a good one. So I think from the literature, what we see consistently with the benefit of physical activity in cancer outcomes, that physical activity is good, some is better than none, and that more is better. So as the field continues to go forward and we learn more things, I think it's interesting to keep in mind. I think it's important to also drop the sort of perfectionist attitude, and knowing that for patients, for their families, that some is better than none. A little bit of physical activity will help. And generally speaking, that more is better for helping to improve outcomes.
Thank you so much. And thank you for the amazing episode, for sharing your expertise and your perspective with us today. It was very encouraging to hear how we can support survivors in meaningful ways and to be aware that we have to personalize it because not one size fits all. So thank you so much for being with us and for your time.
Yeah, thanks for being here today. I appreciate the opportunity.